Okay, great. Thank you. This is a patient who came in with elevated PSA and just got a screening prostate MR. And this is what we saw. So here's actually I put them all in the same image. Here's so this is there's a abnormal. It is multifocal, but maybe the largest area is here in the left mid-peripheral gland, T2 hypointense, and it restricts quite a bit. The ADC is pretty low. And then, I mean, I don't think DC is like helpful in this case, but we have this. So I read this case and then it was, so I called this a Pirates 5 lesion. And then the patient had follow-up.
Ellie, just for my education, did you also call on the right side like something?
Yeah. So I gave multifocal, and I gave this as the index lesion on the left.
Got it.
And then this is a follow-up. Patient got a biopsy before the follow-up, but this was the follow-up, and all of those multifocal findings resolved. So this patient had on biopsy non-caseating granulmatous prostatitis and no history of BCG. 80% of granulmatous prostatitis are idiopathic, so they don't have a history of BCG, even though we commonly hear that all the time. And it's a known mimicker of prostate cancer, and I think it's like nearly impossible to distinguish.
I feel like we've had several cases here of this, and each time I'm sort of like, what's the takeaway? Like, is there some difference like that I could pinpoint?
Yeah. We have.
See how it was like nodular looking? Is that a clue? No.
Yeah, there's different presentations actually. So this one was nodular looking. The other ones are a little bit more hazy. The other types or presentation imaging manifestations, I suspect there's different manifestations of granulomatoous prostatitis, and there's probably a category. We actually I have 50 cases that like I had my trainee like look for pathology proven granulomatoous prostatitis with MR, and we have 50 cases, but we're putting that project on hold because we're doing this other discordant prostate case.
And it also depends on like the chronicity of the inflammation. If it's acute, it tends to be like larger in size and looks like a Pirates 4 or a 5 lesion. And then if it's like subacute to chronic, it looks more like a Pirates 3 lesion. So it also depends on like the timing when we scan these granulomatous prostatitis patients.
Excellent. And Nelly, just off chance, do you know that PSA here?
This patient's PSA?
Yeah.
Yeah, I do. It is 14.6, 15.
Huh. And did it come down after the prostatitis?
Afterwards, it came down to 7.
Huh. Interesting. I guess you just have to biopsy.
Yeah. If anybody wants to do a granulomatoous prostatitis project, I have cases.
Okay. Okay, hold on. Okay, so this patient you can see has cirrhosis, splenomegaly, some gallstones, ascites, and they have this umbilical hernia with ascites going into the hernia. And then something acutely happened to this patient that is related to this ascites and this umbilical hernia. Any guesses? It's a syndrome that I had never heard about.
Flood syndrome, Aarti. I recently heard of it. If that's what it is. Yeah.
Yeah, that's what it is.
Very interesting. Yeah.
So this is called abdominal flood syndrome. So basically it ruptured. This umbilical hernia ruptured and all this ascites came out. And then they repaired the hernia. And I was reading the follow-up and my resident told me like, oh yeah, this patient had abdominal flood syndrome. And I was like, what is that? So anyway, just a few things about abdominal flood syndrome. First of all, I thought, I'm like, oh, that's an interesting name. It's from the ascites flooding out of the abdomen, but actually it's because it was named after Frank Flood, who described it in 1961. He just happened to be the person who named this. And what happens is that about 50% of cirrhotic patients have ascites, and about 20% of cirrhotic patients develop an umbilical hernia. And if they have large volume ascites, that number is up to 40%. So those are the patients that will be at risk for abdominal flood syndrome. And basically the skin just gets like friable and kind of eventually breaks down and can rupture. And I just want to show you the management can be tricky. So here is just a summary of what they have to do. So first they have to do stabilize the patient, do local wound care. It can actually be very morbid. And partially because the patient kind of needs emergent surgery, but they tend to be very bad cirrhotics. They're coagulopathic, they might be thrombocytopenic. It can easily get infected. And actually there, you can have protruding viscera, like your small bowel can come out. So they need to quickly stabilize the patient and then take them for a pretty emergent surgery. So that's what happened in this case. Funny that we both just recently heard of it.
Yeah.
It always comes in waves.
Wow.
So this patient presented with vaginal bleeding. And this was the finding. Nice young ovaries on both sides. Maybe even polycystic, didn't count. But what do you guys think about this?
It's like a giant prolapsing polyp or something.
Good, that's what we thought. And that was the main thing we were thinking about. Any other thoughts?
Fibroid, I mean, on
How old is she?
She is 35.
Oh, 35. Okay, so it's not rhabdo.
I wasn't a child, but actually
Yeah.
I saw a case report of this entity in there were a few of adolescents with this. And it's actually, in retrospect, kind of typical appearance for what this ended up being.
Can you hear me, Aarti?
Yeah, well, sorry, Victoria, what are you saying?
Okay. On contrast, it looks like what's coming out from my meatrium.
Okay, good. Yeah, so it looked like we thought there was like kind of this like big kind of stalk here.
So maybe some weird cellular prolapsing leiomyoma.
Yeah, so that's a great thought, prolapsing leiomyoma, but it's not very T2 dark. It was pretty T2 bright.
You have
There is
diffusion?
like, what'd you say?
You have diffusion?
Uh-huh. Sorry, T2 bright, and then where's the diffusion? Okay, here. So that was the, it's actually not that dark. There was one area here. So I'm just going to cut to the chase. This turned out to be a uterine adenosarcoma. And
what was the ADC on that diffusion?
The ADC,
I mean, ADC, sorry, on the, yeah.
It's not too dark.
Is it under 900? That dot, that's dark right there. Is it 900 or lower? I just finished reading that paper that Nicole Hemming wrote.
No, it's actually 1,000.
It's a good paper, actually. Yeah.
Yeah.
What about that? Right, like right there, right on the around the patient's left lateral like corner.
Oh, this little guy. Let me
Yeah.
see. Get rid of this.
So if you follow that flow chart in Nicole's paper, yeah, can you get that ROI to be any smaller? If it's under 900, then it's highly suspicious for LMS or sarcoma. Still.
Yeah. So, but that was for leiomyosarcoma. And I want to talk briefly about adenosarcoma. I did not know about this entity. And what I learned was that this is actually a much better type of sarcoma to have. It's a combination of benign epithelial elements. That's the adeno part. So all this T2 bright stuff is glands. And so it tends to be T2 bright. That's one of the characteristics. And then the sarcoma part is the sort of malignant mesenchymal component. So it's a combination of a benign and malignant one. And it presents early with bleeding, and it tends to have actually a much better prognosis. It depends on how much of the sarcomatoid portion dominates versus the benign adenomatous portion. And I wanted to show you in the literature, if you Google adenosarcoma, you will see examples that look just like my case. So some of the classic features are that it tends to be a prolapsing mass. So for example, this guy, This one was a high-grade adenosarcoma, but it tends to be a prolapsing mass that starts in the myometrium, but prolapses often to the cervix and vagina. And it tends to be sort of like T2 bright and prolapsing like this. So we brought up polyp initially. So I was also looking up giant endometrial polyps. And here's a few examples. So they can look very similar. They can prolapse, but these actually tend to be a little bit T2 darker, not as T2 bright as like the classic adenosarcoma. So, you know, it's still going to need to be biopsied. This case, they actually resected it. They did, you know, a hysterectomy, but they morcellated it as they removed it. So the path specimen was like pieces, but they basically said that, you know, a lot of this was actually the benign adenomatous component. So thought that was cool. So this is just kind of an interesting show and tell. So this patient has this really dilated pancreatic duct, pancreatic head mass. You can see they're very cachectic. We've lost all of our fat planes and the mesentery and the soft tissues. And they had actually had an ERCP with a stent placed a couple of months before this. You can see that there's some mottled gas in the in both the gallbladder as well as in the biliary tree. And just wanted to show you the stent is actually all the way down here. So it was a metal stent that had migrated out of the CBD into the bowel and was basically transiting through the bowel. And at this point was in the distal small bowel that was going into like a hernia over here. So I had never seen such a, you know, usually these metal stents don't migrate, but here this one was migrated all the way down here. And then there's the mass. There's the bile duct obstructed by the pancreatic mass. Okay, so this was a penile MR. You can see the two cavernosa and the spongiosum. The penis was all distorted, so this isn't like a typical penile MR where we could, you know, kind of strap it onto the patient's abdomen. But does anyone know? So these are the two cavernosa, and we're coming out here. This is one of the cavernosa, and anyone know what has happened with this patient?
There's disruption of tunica, right? One of the.
Yeah, exactly. So if this had been a trauma patient, maybe you could think about a penile fracture, or even actually like, you know, you can get a spontaneous penile fracture. This patient actually had a procedure done. So they had high flow priapism. And so the urologist actually made a disruption in the tunica, and this is what's called a corpo-glandular shunt. So that they can sort of let the blood come out of the corpus cavernosum and go into this and into like the vascular space and get resorbed.
Aarti, do you have contrast? Because that right corpus looks almost like it's thrombosed or something's happening to it.
Oh yeah, no. It's definitely, this is like a chronic thing here. And actually,
Ouch.
so there's the like non-enhancing corpus. And this is the sort of communication with that that area. And then actually we had a follow-up where this started draining to the skin and basically was like infected. So this turned out to become an abscess.
Sorry, you said the patient had a high flow priapism?
Yes.
What was it? Well, like, why didn't they just, like, it's usually vascular, right? I mean, why didn't they just treat that?
They this actually has been going on for a while. Like he had like multiple episodes of priapism, and so that they had done this shunt previously.
Gotcha. But like, do we know what what led to the priapism?
I don't know.
Oh, gotcha.
Yeah. And actually, now that I say it, I'm not sure if it was high flow or low flow. Can you tell me the difference? Like what's the difference in the cause of high versus low flow?
Oh, well, high flow is emergency. And so, I mean, they can get acute ischemic, and usually from like AV, arterial venous flow. Low flow is like from, it's chronic. So I think this is maybe the low flow version, and those are from like sickle cell and stuff like that. So there's high flow is like a urologic emergency, whereas low flow is not.
Okay. And do you know if they do the shunt for one versus the other?
I didn't know that they did shunts for this.
Okay.
Like
'Cause I was
normally
reading
they
about these
just
shunts.
inject. Go ahead.
Yeah, I was reading about these shunts and it was really interesting. They said like there's some shunts where they remove, it's like almost like a circle. So they remove the blood from the corpus and then they put it into the glands of the penis so that it can get sort of resorbed. And then they inject like alpha blockers into the gland. But
Yeah, that was, I didn't know that they did these shunts. Like, yeah, they inject it and then they just like suck out the congested blood.
Yeah. So this is actually the second case that we've had where they've had this shunt where they opened up the tunica. But in this case, it didn't really work because this it was already like really avascular. Okay, this is just kind of an interesting show and tell. Kind of the largest liver I've seen. And a lot of these were actually hemorrhagic fluid levels in sort of like cystic lesions that were basically not enhancing. Show you on the coronal. But a few of the lesions were actually solid masses that were enhancing. So for example, this guy looks different than all of these other ones. So this was like a more heterogeneous solid mass. Here's the post contrast. Actually, sorry, this is the subtraction. So you can see a lot of them were not enhancing, but then there were these kind of like more heterogeneous ones that were enhancing. So this was a big mystery case. We're like, what is this? What's going on here? And then turns out they had a pretty sizable rectal mass, and this turned out to be a rectal neuroendocrine tumor with liver metastases. We still don't fully know if like all of these other lesions were, my theory is that they're just like maybe the patient had polycystic liver disease with all these like hemorrhagic cysts. And then in that sea of cysts, there were these large mets. But we don't really have path proof on these other lesions.
Can we see contrast?
Yeah.
That's great.
So this was the pre. So you can see that there's a lot of blood in both the big mass as well as a lot of these other cysts. So a lot of blood. And then this is post contrast, where this is where I was showing you the subs because it's a little bit confusing, but this big guy here, for example, was enhancing. Now let's just show you the sub. So a lot of those cysts were basically not enhancing. They were just filled with blood. And then this is the venous phase on the post contrast. And I'll show you the arterial too, because I know neuroendocrine. Let's see, let me show you the arterial subs. Kind of a mess. Not super avidly arterial enhancing. But on the more delayed phases, this is the delayed subs, you can see that this guy is definitely enhancing. So just kind of a crazy case. Okay, so this person has bleeding after 4 weeks after a C-section. And there was a C-section scar they were pointing out here. And that black kind of thing there looks like this on color, Doppler. Post C-section, what do you guys think? Yeah. So this was just a really pretty example. And then this is we got a CTA with an arterial and delayed. And we could see that there was this large arterial globular enhancement here. This was the pseudoaneurysm. And on a portal venous phase, it kind of just stayed in that area. So anyway, it was just a large pseudoaneurysm after a C-section. IR went and embolized this. I'm not going to pull up the IR images because it's going to crash my packs. But they showed like, this big pseudoaneurysm here. So they went and embolized this. Okay, that's it for me. Okay, awesome, go.
All right, so my talk was on LI-RADS 2018 with current gaps in knowledge. Okay, so LI-RADS has been around for now 11 years, and it's been a work in progress with multiple updates and multiple scientific evidence. And we've built a very nice kind of puzzle from all the pieces together, but there are still some gaps that remain. And so in this presentation, I talked about these few gaps. And one of the important things is that the system is complex, right? So this is our algorithm for CT/MR diagnostic LI-RADS. We have 8 categories. We have 5 major features. We have 5 LRM features. We have 21 ancillary features. We have multiple rules. We have multiple kind of safeguards. So it may seem like it's a lot. It may be a little too much. But the issue is that imaging of cirrhosis as a subject is a complex subject because we want to detect and characterize HCC, right? And we want to do it with near perfect specificity. But in addition to HCC and cirrhotic livers, we can have all these other benign, premalignant, and malignant entities. So we not only have to detect HCC, we have to separate it from all these other confounding things. Additionally, HCC as an entity is a complex one. So it's not just one tumor, but it's really a group of very heterogeneous tumors which may differ from each other based on histologic features, genetic, oncogenic pathways. All these things may lead to very different pathologic and therefore imaging appearances. And as a result, only about half to 2/3 of HCCs, path-proven HCCs, will look like your conventional LI-RADS 5 lesion. And then they can also meet criteria for LR4, LR3, LRM, LRTIV, and so kind of getting rid of these categories is not going to be possible. So it is a complex system, but it is complex based on necessity, right? We should make everything as simple as possible. We can't really make it simpler. So even though there may be some tweaks going forward that we can do to simplify the approach, but for now, kind of this level of complexity is really necessary. An important gap in knowledge is heterogeneity of LR3 and LR4 observations. You've probably all seen this graph. It's based on meta-analyses looking at proportions of HCC and malignancy per each of diagnostic categories. And you've noticed that between 3 and 4 and 5, the proportions of HCC in each category increases in a linear fashion. And notice that in these categories, almost all malignancies are going to be HCC. So these numbers are very close to each other. Another thing important to note is that LR5, LRTIV, and LRM, almost all lesions that fall into these categories are going to be malignant. And on the opposite spectrum of that is almost all LR1 and LR2 observations are going to be benign. And the issue is going to be our LR3 and LR4 category. When we look at the management per each of the categories, right, LR4, 5, and LR5, M, and TIV, which are our nearly always malignant lesions, straightforward, they go to multidisciplinary discussion for treatment. LR1 and 2, along as patients who have no lesions detected or have non-diagnostic studies, they go back into the routine surveillance. But LR3 and 4 are where the confusion and difficulties lie. If we look at the kind of breakdown of where the categories versus entities fall, again, notice that some HCCs, especially early HCCs, will fall into LR3 and L4 categories. So at any given moment of time, of all LR3 observations, about a third is going to be HCCs, and of LR4, about 66, 67% are going to be HCC, but the rest are not HCCs, right? So what happened to LR3 observations when we follow them? A large range, up to 60% will just stay LR3. Up to 68% will actually decrease in category. And then a minority, but very important minority, will progress to high categories, including frankly malignant. And just some examples here is our LR3 hepatobiliary phase hypointense nodule, right? It has one ancillary feature of malignancy. It is unchanged for 3 years. So even though it's stable, we cannot decrease the category. So this is an example where LR3 just stays LR3.
Victoria, quick question. That one that was the LR3,
Yep.
You basically are only seeing it on the hepatobiliary phase, it looks like, right? What is the pathology of a lesion like that? Is it like an infarcted nodule or like just a regenerative nodule?
These are usually dysplastic nodules, and given stability, this is probably low-grade dysplastic nodule.
Okay.
Right.
And then what about a nodule that like is T1 bright but doesn't really show enhancement?
Okay, good. So this is an example of such a lesion.
Okay.
So this one is T1 bright. It has no major features. I'm not showing the entire case, but it didn't have any ancillary features of malignancy, and it was hyper-enhancing on hepatobiliary phase. So if this was smaller than 2 centimeters, we could have just said this is LR2 distinctive nodule and proceed, just as an LR2. But when such nodules are over 2 centimeters, by rules, they cannot meet, we cannot call them LR2 distinctive nodule because one of the criteria is the size less than 2 centimeters. So just based on the size, this has to be an LR3 observation. But so for 5 years, this has not changed. So because this has no ancillary features of malignancy, like the case I showed you before, we can actually decrease the category because size stability is ancillary feature of benignity. So in this case, this is an LR2 observation so LR3 that went to LR2.
I didn't know that. So you're saying LR2 has to be at least 2 centimeters or less?
No. There's a distinctive entity, an LR2 category called LR2 distinctive nodule. Okay, so that entity has its own criteria. So LR2 distinctive nodule is a nodule that is less than 2 centimeters and then has no major features, LRM features, or ancillary features of malignancy. So sometimes it's a T1 hyperintense nodule that stands out. Sometimes it's hepatobiliary phase hyperintense nodule that stands out. Sometimes it's a T2 hypointense nodule. Right? Does it make sense? So if you see a nodule like that and it stands out but has no features of malignancy, that can be assessed as LR2 distinctive nodule, so one of the LR2 entities, but it has to be less than 2 centimeters. So if this nodule was less than 2 centimeters, we would have called it LR2. But because it's over 2 centimeters, we can't. Does that make sense? Is that correct?
Yeah, no, it totally makes sense. So what I didn't know was if you do have a distinctive lesion and it looks benign to you, you can only call it LR2 if it's less than 2 centimeters.
No. If you see something, but it's only the 2 centimeters applies only to this LR2 distinctive nodule. So for example, if you see
but aren't most like lesions like the
let's
ones that don't
say
have ancillary features or minor features,
No,
like they would be distinct nodules, no?
So these nodules are not common, right? But it doesn't. So this 2 centimeter cutoff does not apply to all LR2 observations. So for example,
No, not all LR2 observation, but like observations that are nodule. Okay, I have to reread the LR5.
There's a subset of LR2 observations, right? So LR2 probably benign. So if you're looking at and you think something is a thrombosis hemangioma, you're fairly certain but not 100%. that has no size cutoff. You can just say LR2, probable thrombosing angioma.
Yep.
But there's a distinct entity called LR2 distinctive nodule, right? That entity, that specific entity does have size cutoff. Does that make sense? So imagine.
So
imagine-
any lesions that don't look like typical anything that's benign then becomes a distinctive categories, and it has to be like LR distinctive nodule too,
Yes,
unless there's stability.
Right, it cannot have any features of malignancy. So no major features, no ancillary features, no LRM features. So if it's a T2 hyperintense, that's it. You can't be in that category anymore. If it's hypointense on hepatobiliary phase, that's it. You can't be in that category. Does that make sense?
Yeah. So like, I mean, if I think like what you're showing, right? A T1 hyperintense lesion without
Right.
any other concerning features, then
Correct.
you still have to use a size. Otherwise, it becomes a 3, even though it looks
Correct.
benign.
So, but such nodules are uncommonly over 2 centimeters. But this one was, right? So this one was, so by rules, this was LR3. It stayed stable for over 5 years. And because it stayed stable, it doesn't have any unopposing ancillary features of malignancy, you can decrease the category. Okay, and this is up to quarter LR3s will progress to 5 or M within 24 months. This is an example. T2 hyperintense, T2 slightly hyperintense, diffusion restriction, hepatobiliary phase hyperintense nodule. And then in 2 years, this progressed to your typical LR5. For LR4 observations, within 12 months, about 44% will stay. About a third, just over a third, will progress to 5 or M. And then a minority, but again, a minority that's important will actually decrease in category. So this is just an example. Here's LR4, right? 9 millimeters enhancing without washout and just hepatobiliary phase hypoenhancement. That's an LR4 observation. In 9 months, it meets all the criteria for LI-RADS 5. So if we look at cumulative incidence of HCC, right? So this is LR3. So you can see that there's steady increase in cumulative incidence of HCC for about 3 years and a little bit quicker upstroke. And then LR4 category has a kind of more steady curve. So by year 4, over 80% of LR4 observations will progress to HCC, and just over 60% of LR3 observations will progress to HCC. So that seems like a good, a big number, right? We can't ignore them. If we look at LR3 observation cumulative incidence based on different modalities, in this study, they showed that really there was no difference. So it doesn't matter if LR3 is detected by CT or MR, the incidence is going to be very similar. And the reason why it's a problem is because once we call something LR3, we should follow it fairly closely every 3 to 6 months. So if we go back to this curve, it's true that by year 4, about 60% of these lesions will progress to LI-RADS 5, but all of these instances will not, right? And imagine we have to keep imaging these patients every 3 to 6 months. So just imagine the number of patient exams that will happen in these years that will amount to nothing. You can imagine this is a big burden on patients, on healthcare, on us. And we're not really helping anybody. With LR4, it's a little less problematic, right? Because patients should be sent to multidisciplinary discussion, and then they can get a biopsy, they can get treated presumptively. But still, sometimes we treat patients who didn't quite make it to HCC, or patients have to undergo biopsy. So again, a lot of extra steps need to happen. There are studies that look at prediction of progression. So all of these kind of things indicate higher independent risk for progression. But again, even though we know that these things are kind of put patients in high risk, we really don't know how to integrate all of that and really estimate the risk and identify those LR3s and 4s that can be followed less aggressively versus those that can be either followed aggressively or maybe even treated. So we're really missing a mark of this one.
What is for the tumor growth, threshold growth, what does it mean prior to index date?
So let's say you have LR4 today, and then previously it has been growing. That makes sense? So it has demonstrating threshold growth by the time you're imaging it. So not in the future. Does that make sense?
Kind of.
Like you started with lesions and let's say LR4, and then it's already demonstrated at some point threshold growth prior to today, calling it LR4.
Yeah, so you feel like it's on the move. So it's like not just an LR4, but it's like you're catching it on the move.
Correct. Like it's increasing in size. Like
so like, oh, go ahead.
Oh, go ahead.
Threshold growth is like less, within 6 months, 50% or more growth.
Yes.
So like if you have, so to me that's like 2 time points.
Correct.
And what I hear is, well, if you have 3 or more time points,
No, you don't need 3 times, but let's say you like we're looking at a 1.5 centimeter LR3 today, and 6 months ago it was 0.7 centimeter, right? That is a higher risk of progression to full-blown HCC than LR4 today, 1.5 centimeters, and 6 months ago was 1.1 centimeter. That's what it means.
and because I mean, threshold growth is one. Okay, yeah, that makes sense. I do have a question. Like if I have a lesion that grows by 40% at 5 months,
Nope.
and then on the 7th month, it now it becomes 60%. That doesn't count, right? Because that's not within 6 months. That's like 7
No,
months.
unfortunately, no.
Okay.
I know that logically makes no sense, right? But the definition of threshold growth is very strict based on OPTN criteria. So anything that doesn't fit that mold strictly becomes subthreshold growth. I know that sometimes it doesn't make any sense, right? So if you have something that doubled in 12 months, kind of intuitively you want to say, well, in 6 months it was 50, you know what I mean? Like it's something that had 100% size increase in 12 months, the same growth rate as 50% in 6 months. But again, because of how OPTN was their definition, that's how we were sticking to it. All right, so this is a very important gap in knowledge because NIH put out this RFA like about 2 months ago, and what they were looking for, they acknowledged this is a major unmet clinical need to ability to stratify the indeterminate lesions, and they used LI-RADS 3 and LI-RADS 4 as a definition of these indeterminate nodules. All right, so the next gap in knowledge is this imperfect intermodality agreement. And just to remind everybody, these diagnostic CT-MR is equally applicable to CT-MR with extracellular contrast agents and hepatobiliary agents. And just an example, to give an example of what we see sometimes, we see this lesion that was diagnosed in an outside institution, no arterial phase hyperenhancement. It does become hypoenhancing, so there is washout. So based on our table, this would be LR4. But then patient had a repeat MR, repeat study when they came to our institution. Now we do demonstrate arterial phase hyperenhancement, washout, and capsule. So now, based on these imaging features, we would diagnose this as LI-RADS 5. And this difference between CT and MR is not uncommon. Based on literature, it can happen anywhere between 36 and 71% of the times. If we take away the LR1 observations, usually MR gives us a higher category, but sometimes CT gives us a higher category. And we know that some of the, there are multiple factors that contribute to these discrepancies. The modality specific sensitivities and specificities are different, right? Then there are some features that can only be assessed in MR, like, for example, diffusion weighted images. So all of those contribute to discrepancies. So the ultimate solution would be something fairly complex, like you can see here, right? We will take into account imaging modality, then all kinds of things like observation features, patient level and liver level features, then some clinical factors, biomarkers, and then some sort of AI model will put it all together and give us a very discrete point probability for any given lesion for particular patient, and hopefully not only probability of HCC, but also some sort of prognostic information.
Victoria, Nelly in the chat had asked if there was a calculator like for LI-RADS and CCLS, and this seems like this slide seems like it would be ripe for like making a calculator with all these different things. Are you guys starting to work on that, or?
So we this is our desire. This is our future goal. This is our 20-year goal. But we need huge data registries to get there. And it wouldn't be practical to have it as a calculator with all these features where by hand you would put this together. Most, ideally it would be something like a computer model, a computer program which will pull a lot of information from Epic. You would input some information, maybe some texture analysis that the machine does, and all of that gets put together and machine spits out the probability. But this is just a tremendous look ahead 20 years from now. So this is nowhere near even.
Yeah, this is like the more advanced version of what basically happens at tumor board, like where the clinicians are taking all these other factors into account. And
correct, but one day in the future, hopefully this will happen where the AI will assist us with making these complex models in a relatively quick and easy fashion.
I know we're always saying AI, but I think we're doing a pretty good job. It's like the 80-20 rule, right? Like what we have meets 80% of the needs, and maybe AI will add the additional 20%.
Right.
But I mean, the chunk of it is still like being taken care of by the current workflow.
That is correct. But for example, this probability of recurrence or probability that this particular lesion will respond to this particular treatment, we're in the infant stages of making that determination. There's some data beginning to emerge that we can predict that a lesion with these features will be more aggressive, but we still don't know what to do with that information, right? Like, do we offer the patient extra, do we start them on immunotherapy early? Sometimes, you've all seen it, right? Sometimes you give, one lesion will respond to immunotherapy, one won't. So all these things, I think that's where value of AI will be, where they can predict things that we cannot. Like AI doing what we can do is to me is not a great value add, but AI doing things that we cannot, including predicting outcomes, predicting responses, predicting recurrences. That's where AI is going to come in and really shine. Anyway, but all of that is beautiful, but what do we do with cases like this right now? We have LR4 on CT, LR5 on MR. Do we stay more careful, more conservative and say, no, it's going to be LR4? Do we just say, no, this is LR5? Like, how do we, what do we do now and not 20 years from now? So this is a recent IMPRESS meta-analysis that we did. Again, these dots represent the averages, percent of HCC malignancy. So similar to what I showed you before with little boxes, but if we separate these dots based on modalities, you can see now they become separated a little bit. But notice that for LR5, the percentages of HCC malignancy are pretty much identical regardless of which modality is used. Same thing for TIV, almost all are malignant regardless of modality. Same thing for LRM, almost all are malignant regardless of modality, which means that if you have a modality, you have two discrepant answers for a given lesion, you would go, once a lesion meets criteria for either 5 or M or TIV, you go with with that, right? So in this case, this met the criteria for LI-RADS 5, which means that we can keep it at LR5 and report it at LR5. We're 2 minutes past the hour, before the hour. Should I stop? I have like a couple more minutes to go.
Yeah, maybe can you wrap up in a few minutes? Okay.
All right, so the last thing is imperfect inter-reader agreement, right? And there are 2 large meta-analyses that looked at it. And the bottom line is that we have substantial inter-reader agreement for both modalities, for features and for the categories. And substantial is pretty good, but not perfect. And the reason being is that we currently assess our features in a qualitative manner and compare it to background. The background is heterogeneous, right? And depending if I choose this part of the liver, I'll say there's no AFI because the enhancement is identical. But if I choose this part of the liver, now there is AFI. And there's really no rules or guidance as to what you should do in situations like this. Lesions are heterogeneous, right? So again, I can choose, majority of the lesion, right? In which case I will say no washout, but this tiny little area looks hypo to the parenchyma, so that would be a washout. And again, there's really no rigid rules explaining what to do. So inter-reader agreement is not perfect, but LI-RADS may be doing as good as we can get for qualitative features. This is again our kappas for LI-RADS, but they are way better than for BI-RADS and way better than PI-RADS. So potentially the substantial agreement may be as good as it gets. And honestly, by reviewing various studies for various, not only LI-RADS, but other things, it may be it. Like we may not get better than a couple of 70s when we talk about a qualitative assessment of features. And the ultimate solution may require some sort of quantitative assessment of features based on II, if really we need to have a higher agreement for feature assessment. Anyway, so to summary, we still have a complex algorithm. We may be able to simplify it a little bit in the future, but it will need to stay somewhat complex because of nature of the disease. Heterogeneity of LR3 and 4 outcomes is very important. And then we have imperfect intermodality agreement, imperfect inter-reader agreement. And again, to solve a lot of these issues, we will need like large data sets to close the gaps. There you go.
Learned a lot. Thank you.
Awesome. Thank you. I have a question. You said in the predictors of growth or aggressiveness, HCV was one of the predictors. Where does like alcoholic cirrhosis and NASH cirrhosis fall? What's your kind of, I don't know, just summary statement about like the risk? So
there's no good data that says, like if you have LR3 in NASH, it's going to behave better than, than if it's hep C cirrhosis. I don't recall any data on that. Potentially it is a factor. We think that probably the state of liver itself is going to be more important than the cause, right? So if you have more advanced cirrhosis, that's probably going to be a worse situation than if you have kind of earlier cirrhosis. There is data that shows that if you have an LR5 or LR2 elsewhere, then the probability that LR3 or LR4 is HCC is higher in those patients, which also kind of makes intuitive sense. But right now we don't have, we don't say, the algorithm doesn't take that into account because we still go by per lesion assessment.
Okay. I was just curious because we're predicting a sort of epidemic of NASH cirrhosis, right? And I heard or read somewhere that but then the likelihood of having an HCC and NASH cirrhosis is less than the hep C epidemic that was kind of rose up from the 70s. So I was just kind of curious if we're going to see more cirrhosis, but less HCC in the future, but sounds like.
I don't know. I have a bunch of really aggressive HCCs in pre-cirrhotic NASH patients.
Okay.
Stage 3 fibrosis, and they're pretty ugly. I had a bunch.
Yeah.
I've collected. So I don't know. I think there's also going to be maybe component of inflammation that's going to come into place. I mean, all of these things need to be evaluated. Really exciting.
I have another question. I think I misread the slide. So that meta-analysis, LR1 through 5, it says 75% or 95% for LR5.
Mm-hmm.
But then on a few slides prior, it says LR5 was up to 75%.
No,
and I think I misunderstood if it was PPV or something else.
No, you must have misread. LI-RADS 5, the PPV is about 95%. And right, so 75% is the LR4. So LR4, depending on category. So in earlier categories, the PPV of LR4 was close to 75. With V 2018, it went down a little bit because a bunch of what used to be LR4 now became LR5. So now it's about 66.
And the other question is, you know how we're supposed to, BI-RADS have the RAD path review, and PI-RADS now requires RAD path review for ACR designated center. I guess, I mean, I haven't really seen that for our liver, but maybe it's less of an issue than like the other RADs.
It's not because again, liver is unique, or HCC is unique in that we created the rules in a way that LI-RADS 5 does not require path correlation. So yeah, I mean, I guess in a transplant center you could, but that's probably the only time you could do it.
But most of these numbers, these 95% numbers, is coming from path proof, right? So like it's transplant centers.
Transplant center sections. You know. I mean, honestly, if it's used correctly, it works. But the key is that it has to be used correctly, right? So it has to be using correct patient population. You know, you have to remember all the rules, which I know are annoying, but they're there to maintain this really great performance, and so you don't have to biopsy things.
Awesome. Okay, I'm going to stop the recording.